Alright, now that we're done with the diabetes drugs, the rest of these should be pretty quick. Remember what these drugs do? I mentioned them in the pathology section. Propylthiouracil, also known as PTU, and methimazole are antithyroid drugs used to manage hyperthyroidism. They both inhibit thyroid peroxidase, which is arguably the most important enzyme in thyroid hormone synthesis. In addition, PTU blocks peripheral conversion of thyroid hormone to its more potent form, T3. And both of these result in decreased thyroid hormone activity. Now, methimazole is usually the preferred drug because PTU is associated with a small chance of fulminant liver failure. But PTU, on the other hand, is the drug of choice during pregnancy because methimazole is a possible teratogen. The way I remember this is that PTU involves peripheral conversion and is used in pregnant patients. PPP. Now, both drugs have some side effects in common. The common one is skin rash, but the one you're likely to see on step 1 is agranulocytosis, or aplastic anemia. Now, this complication is pretty bad, and if you prescribe either of these drugs, you have to be on the lookout for either one of these. When would you suspect agranulocytosis in a patient on antithyroid drugs? I mean, sure, if they come in with severe sepsis or a major infectious complication, you know there's something wrong. But your index of suspicion needs to be even higher. A lot of the times, the first warning sign that there might be agranulocytosis is if a patient starts to have mild recurrent URIs. If a patient develops a chronic cough after starting methimazole, it's time to get a CBC. If you know what thyroid hormone is, then you already know pretty much all the information that's already going to be on this slide. What's levothyroxine used for? The answer is to replace thyroid hormone in hypothyroid patients. Levothyroxine is basically just the synthetic version. Now, what are the symptoms of an overdose? In a nutshell, hyperthyroidism. Your classic constellation of tachycardia, heat intolerance, increased appetite, weight loss, sweating, diarrhea, agitation, etc. And that really is all you need to know about thyroid hormone. Well, alright, I feel like I need to give you guys something a little bit more interesting because you're paying money to listen to me yap. Because it ramps up metabolism and gives you energy, some patients try to get thyroid hormone specifically to lose weight. Now, this is not an approved use, nor is it particularly safe because of the risks of tachyarrhythmias and overheating. But it happens, and it's something to be aware of in case it pops up as a psych or a medical ethics question on step 1. Just know that these folks aren't going to be complaining of weight loss. They'll probably be more concerned with side effects like anxiety, sweating, and possibly even symptomatic tachyarrhythmias. Now, if you went over the physiology and pathology sections already, you probably already know these drugs pretty well. So let's use this as an opportunity to blitz through these and test your awesome knowledge of hormone therapies. I'm going to give you 2 seconds to answer each one, so if you need some more time on these, pause the video. First question, what are the Vaptan drugs used for? It's all in the name. Vasopressin receptor antagonists antagonize the ADH receptors. And when do you need vasopressin? When it's too high, namely during SIADH. Next question, what is desmopressin and when do we use it? Desmopressin is a vasopressin analog, so we use it to replace the missing vasopressin in central diabetes insipidus. Central, not nephrogenic. It's not going to work for nephrogenic DI. Next, what is growth hormone used for? No, I'm actually not kidding. We didn't go over this in either path or physio, but I'm sure you can figure out that it's used in growth hormone deficiencies. What you might not have guessed is that it's also used to help girls with Turner syndrome grow. But of course, when do you have to start it in order for it to work? You have to do so before the epiphyseal plates fuse, otherwise you're just going to have a bunch of short women with huge hands and coarse faces. Next, what is octreotide and what is it used for? See, this one's a little bit trickier, because it's actually used in a bunch of different situations, both in the central nervous system and in the GI tract. Pause the video and see if you can get them all, because we covered a bunch of them in the Pathophys lecture. Alright, time's up. Octreotide is a somatostatin analog, meaning that it acts in the CNS as a somatotroph, and in the GI tract to inhibit pretty much everything. So it's used to suppress GH-secreting tumors that lead to acromegaly and gigantism, as well as to suppress hypersecretion by all the GI endocrine tumors we talked about. Glucagonomas, insulinomas, carcinoid tumors, and gastronomas. Finally, and this is a use they talk about more in the GI section, They use it to help reduce the portal venous pressure, which helps take the pressure off esophageal varices if they're bleeding and need to be treated endoscopically. Finally, and this isn't one we talked about much at all, oxytocin, which is in the domain of repro. Its primary use is to stimulate contraction of the uterus. This makes it like the holy grail of obstetrics because you can use it in 3 different situations. You can use it to try to induce labor by kickstarting some contractions and seeing if mom can take it from there. You can use it to strengthen the uterine contractions in the middle of labor in case moms aren't strong enough. And finally, if the uterus is bleeding more than it should after the delivery, you guessed it, chances are it's not clamping down hard enough to block off the uterine vessels. Oxytocin can help here as well with controlling uterine bleeding. Now these are the medical uses, but remember that oxytocin is physiologically used to release milk while the baby's nursing. It's called the milk letdown reflex. I mentioned dimethylcycline earlier. First of all, what class of drug is it? It's actually just like it sounds, a tetracycline. So what's it doing here in the endocrine section? Well, it's 1 of 2 drugs you need to know, including lithium, that causes nephrogenic DI. Dimethylcycline can be used to induce mild vasopressin resistance that treats SIADH. On the note of toxicities, though, too much of it can cause the patient to swing from SIADH to full-blown diabetes insipidus. Dimethylcycline can also cause the other side effects common to the tetracycline family, such as photosensitivity and calcium chelation. Glucocorticoids is something we spent a long time on in the endocrine section that will keep being relevant in many of the other sections. In general, what are glucocorticoids used for? And by the way, everything is not an acceptable answer. Broadly speaking, glucocorticoids are used to suppress the immune system, treating a wide range of autoimmune diseases and transplant rejection, inflammation, including asthma, and allergies, as well as certain cancers. Most relevant to this section, though, it's used to replace cortisol in certain conditions defined by low or absent cortisol, like Addison's disease and congenital adrenal hyperplasia. Now, I hope y'all remember this. What's the most common cause of Cushing's syndrome? Kind of a leading question since we're in the pharm section, but the answer is that it's a side effect of exogenous glucocorticoids. And because of this, I want you to pause the video and run through this with me one last time. What symptoms can you expect from a patient with Cushing's syndrome? I realize I made you stop and think about this on 3 separate lectures now, but cortisol is the most complicated hormone on the endocrine section, and it's extremely important in multiple subjects, so just humor me. You can even use cortisol the high-strung gunner to help you out. So cortisol the high-strung gunner is known for his many emotional breakdowns, so it makes sense that he epitomizes catabolism, or breakdown. The gluconeogenesis, proteolysis, and lipolysis cause peripheral wasting, but the mobilized macronutrients end up depositing as fat in weird places, leading to the classic Cushingoid habitus. And remember, that as a part of the catabolic profile, cortisol increases insulin resistance, which can lead to the development of type 2 diabetes. As per our mnemonic, the gunner's always running around with a sky-high blood pressure. He's emotionally fragile, which is mirrored by structural fragility. Bone growth and soft tissue repair are severely impaired, leading to osteoporosis and poor wound healing, as well as the big purple stretch marks known as striae. The stress makes him sick because cortisol causes immunosuppression. And although nobody wants to mention it, our high-stress gunner is probably well on his way to some sort of legitimate mental disorder. One very common side effect of hypercortisolism is psychiatric changes, which can range all the way from anxiety and depression to frank psychosis. Finally, cortisol can lead to menstrual irregularity or amenorrhea. It's not entirely clear why cortisol disturbance is responsible for these side effects, but it's definitely common enough that you need to know it. Finally, remember what happens if you discontinue cortisol too fast? That's when you get tertiary hypocortisolism, from having exogenous cortisol suppress your own production for so long. Literally, it causes the adrenal gland to atrophy from underuse. So, fortunately, the list of symptoms isn't quite as long as the other one. What symptoms are you going to see? The cortisol deficiency leads to hypotension, hypoglycemia, and weakness, and GI upset and anorexia. Alright gang, because we love cortisol so much, let's wrap up our discussion with cortisol with one final flash quiz. Where might a patient who chronically takes prednisone be expected to store fat? Now don't think too hard about this one. The answer is, if you're not sick of this one already, the typical Cushingoid distribution of fat. It deposits in the face, known as moon facies, the back of the neck, known as the buffalo hump, and in the abdomen. Another part of the Cushingoid habitus is the peripheral wasting. While you'll see a lot of central deposition of fat, the arms and legs will actually become quite skinny. It's a very characteristic habitus. Fludrocortisone, also known by its adorable trade name Florinef, is a drug you've most likely never heard of before, and in a slightly counterintuitive way, it's not used as a glucocorticoid. It's actually used to mimic aldosterone, much like dexamethasone and prednisone are used to mimic cortisol. So obviously, its main use is in people who don't have enough cortisol in the first place, namely people with adrenal insufficiency. Some of the side effects are pretty intuitive as well when you realize that aldosterone's primary function involves fluid retention. So what sorts of things do you think this might cause if you give someone with adrenal insufficiency just a little too much fludrocortisone? Hypertension and edema can occur, and you should also remember that a person who's unlucky enough to have both CHF and adrenal insufficiency has to be extra careful, as dosing this drug wrong can easily lead to an acute exacerbation of their heart failure. Hypokalemia can also occur, as aldosterone wastes potassium in order to conserve sodium in water. Now, the interesting thing is that while fludrocortisone has powerful mineralocorticoid activity, it's actually created based on a cortisol molecule. The only difference is that they add a fluorine molecule down at the bottom. And if that doesn't sound like a major change to you, think back to OCHEM, and remember that fluorine, being the most electronegative molecule, creates a powerful electrical pull within the atom that changes the whole electrical topography, or dipole of the molecule. That being said, since the atomic structure is still a lot like cortisol, the molecule still has some glucocorticoid activity, meaning that in some people it can cause a mild Cushing syndrome. For my final words of endocrine wisdom, I'd like to leave you with something we've never talked about before. Cinecalcin. Okay, it's not that exciting. You could probably guess it has something to do with calcium. The parathyroid gland normally detects calcium using calcium sensing receptors, or CASRs. Remind me again, how does increased calcium affect the release of parathyroid hormone? So elevated calcium decreases the levels of PTH, and cinecalcin is able to allosterically sensitize the receptors, making them much more likely to downregulate PTH production. It makes sense then that cinecalcin's main use is in primary or secondary hyperparathyroidism, and that the main consequence of overdose is hypocalcemia. And that does it for endocrine pharmacology. By this point, your brain has been armed with the entire arsenal of endocrinology info you need to ace this test, so go ahead and pat yourself on the back for that one. But as you already know, you also got to be able to apply that knowledge in a test-taking scenario. We're going to finish endocrinology on a strong note with a couple of board-style questions. Now, these are pretty hard ones, so don't get down on yourself if you don't get them right. When you see these questions, I'm going to give you some time to read and solve them. Then I'll go over not only what the right answer is, but also how you should be thinking about these test questions as you do them. Everyone got that? All right, let's start with the first one. A 16-year-old girl comes to the physician concerned that she has not yet begun menstruating. Her blood pressure is 160 over 100 millimeters mercury. Physical exam reveals anatomically normal female genitals, but lack of any secondary sexual development, including breast buds or pubic hair. In this patient, hormones from which layer of the adrenal gland showed in the image above are overproduced? Zone 1, Zone 2, Zone 3, Zone 4, or Zone 5? 5 seconds. Pause if you need more time. Alright, that wraps it up. Let's break this question down. So, this may just be my emergency medicine approach to things, but what's the very first thing you want to read when presented with a multi-step step 1 vignette like this? If you said, the first line, duh, that's actually incorrect. In fact, it's the last line you want to prioritize because that's where the question is. So the question asks us, which adrenal cells are overproducing hormones? And knowing that the question's about an adrenal problem gives you a huge advantage. I mean, if you started with the first line, a 16-year-old girl with primary amenorrhea, that's actually a humongous differential. It involves both endo and repro, and while that's kind of what you have to work with in a clinical setting, this is step 1, and you got to answer these questions as efficiently as possible. So, what kinds of adrenal problems might cause amenorrhea? Remember that the adrenal cortex produces aldosterone, cortisol, and sex steroids, while the adrenal medulla produces catecholamines, epinephrine, and norepinephrine. Of all of those, only the underproduction of sex steroids could give the patient the presentation that we see in the vignette. Remember that an overproduction of adrenal androgens would lead to virilization, and our patient has normal female genitalia. Increased cortisol could lead to menstrual irregularity, but it definitely doesn't lead to a complete lack of all secondary sex characteristics. But that doesn't answer our question of which hormone is overproduced. If you got tripped up making a careless mistake here, then definitely make sure to read the last line carefully before the vignette. If you did read the last line, then at this point, the notion of one hormone being increased and the sex steroids being decreased should at least lead you to think about congenital adrenal hyperplasia. At this point, if you know all three of the common CAHs well, you'd be able to say right off the bat that the only one that shuts down the production of sex steroids is 17-alpha-hydroxylase deficiency, which causes increased aldosterone. But if you're a little rusty on your hyperplasias, it's a little tougher because in theory, increased aldosterone, cortisol, or catecholamines could increase the blood pressure. But look at it this way. First of all, congenital adrenal hyperplasias always involve decreased cortisol. That's the whole reason that the gland experiences hyperplasia in the first place. And catecholamines, which aren't even affected by CAH, by the way, typically also cause other pretty recognizable symptoms like sweating, palpitations, and anxiety, not just increased blood pressure. So you're left with aldosterone either way you look at it. So the final step, you have to interpret this adrenal slide. Don't complain, by the way, I warned you about this in endocrine anatomy. First of all, you have to find out which side is the cortex and which is the medulla. Now in this picture, the medulla is pretty easy to spot because it's more basophilic and also more porous because of all the vessels inside of it. The capsule's kind of cut off in this picture, but it's pretty safe to say if 5 is the medulla, then 1 has got to be the capsule. From there you can figure out that 2 has got to be the glomerulosa, 3 is the fasciculata, and 4 is the reticularis. And which one of those produces the mineralocorticoids like aldosterone? Remember, the deeper you go, the sweeter it gets. So salt has got to be the outside layer, the glomerulosa, closest to the capsule, which is answer choice B. Oh, and for those of you who are wondering, yes, the adrenal gland mostly produces weak androgens. But even though a woman's secondary sex characteristics generally arise as a result of estrogens, estrogens are created from the aromatization of androgens. So no androgen production means no estrogen production. Last question, guys. This one's a bit more straightforward, but it's an important teaching point. Y'all ready for this? A 30-year-old woman presents to her primary care physician with irregular periods. She reports previously having normal periods since her menarche at age 14 years. However, her last 5 periods have been irregular with varying length and amount of menstrual blood. She worries that she's undergoing menopause because she has also felt very hot, had difficulty sleeping, and has had unexplained diarrhea over this same duration, though she denies any travels. Her pulse is 106 beats per minute, blood pressure is 140 over 90 millimeters mercury, and respiratory rate is 14 per minute. She's found to have positive thyroid-stimulating immunoglobulin. Which of the sets of data in the table best describes this patient's disease process? And all of the answer choices have to do with TSH, T4, palpation of the thyroid, radionuclide uptake on thyroid scan. 5 seconds. Pause if you need more time. And time's up. Let's check this one out. So, if you jump down and skim the last line of the answer choices, you already know that this is going to be a thyroid question. Which makes your life a whole lot easier because this vignette actually seems to be pointing towards premature menopause for a while. This one's only 30, which makes menopause a lot less likely, but in a 50-year-old woman, hyperthyroidism and menopause can actually look very, very similar, with irregular menses, hot flashes, sleeplessness, agitation. But this question basically says it's a thyroid problem, and the last line of the vignette tells you that she's positive for thyroid-stimulating antibodies. So what disease are we dealing with here? This one's a classic picture for Graves' disease. In addition to the symptoms I just spoke about, plus the, thyroid-stimulating antibody, which really diagnoses Graves' disease, she does show some signs and symptoms that don't fit the profile of menopause, such as diarrhea and mild tachycardia. So the question is, which one of these best fits the profile of Graves' disease? Remember how to answer these data table questions. Aggressive process of elimination, starting with the column you're most confident of. In this case, I think we can all agree that Graves' disease is a form of hyperthyroidism, meaning that D is incorrect. And since it's primary hyperthyroidism, an increased T4 means a decreased TSH, meaning B is incorrect. If you compare A and C, the radionuclide uptake doesn't really help you any. Both of them are high. Now your job is to figure out how a Graves' thyroid feels, and the answer is diffusely enlarged. Remember, nodular goiters are the other major class of hyperthyroidism that you have to know about, but the question already practically tells you that the patient's got Graves. Remember, she's got positive thyroid-stimulating antibodies. Now, that's only 2 questions, but I'm sure I don't have to tell you that doing a lot of practice questions is as important to success on the boards as just knowing the info. I highly recommend the QMax question bank, and no, I'm not just saying that because Dowley will beat me if I don't. It's actually a great question bank that's very reflective of the range and style of questions that you'll see on Step 1. If you've all been listening since the beginning of endocrinology, props to you, and thanks for your undivided, or at least minimally divided attention. If you like these videos, let me know by giving me a thumbs up down below, or leaving a comment if you have the time. If you check out the psychiatry section of First Aid, I'll see you there, but until then, Arjun Iyer, signing out.